He did diploma in research and development of products of public health needs in 2015 in University of Nagasaki in Japan. He is currently the consultant biologist at National Hospital Kandy, and he's helping the National Hospital's patients as well as patients in the surrounding areas with these investigations, especially with regard to hepatitis B viral infection. So over to you, Rohita.
Thank you, Kulisha, for kind introduction. Good evening to everybody. So today I am going to talk about the management of hepatitis B viral infection in the local setting. Mainly here I will focus on mainly on the diagnostic aspects in our resource poor settings. I will briefly give some introduction, then move into epidemiology, virology, then the transmission, the pathogenesis, the clinical features, then diagnosis and management. And at the end, I will briefly discuss how we utilize available resources to get maximum outcome. Hepatitis B infection has been recognized as a disease since ancient times. Actually, there's a hypothesis that this virus might be originated from other species, and there are cross-species transmission, and then it was well adapted into the human as a human pathogen. Now, human hepatitis B virus is only human pathogen. This hepatitis B virus infection can potentially cause life-threatening liver infection, which may result in cirrhosis or hepatocellular carcinoma, and now it's considered as a major global health problem. Moving on to epidemiology, hepatitis B infection has a complex epidemiology. It's depending on the population's prevalence, their age, the manner of its acquisition, and how it clearance or how it get progression. The epidemiologies vary from different parts of the world. Considering through burden of the disease in 2019, WHO has estimated that 296 million individuals had chronic hepatitis B infection, and every year they estimated that 1.5 million new infections occurring in the world. I think it has a large burden to the public health and the global health problem. And also, hepatitis B infection is contributing nearly 820,000 deaths per year due to hepatocellular carcinoma and the other disease complications due to liver infection and the cirrhosis.
Rohita,
yes.
Sorry, we can't see the slides moving. I think you have to click resume slideshow on your screen.
Now it's moving.
Not really. There's a small box saying resume slideshow.
Yes.
Maybe if you click that.
Now it's moved.
No, we can see the slide with side of the overview.
In my screen, actually, it's moving.
Maybe you can share again. If you,
yes, maybe, yes. Now moving.
We still see the overview slide. There's a small box above the overview slide, resume slideshow. I can see it on my screen. I don't know whether you can see it there.
Yes.
Above overview, there's a small box slideshow, resume slideshow above overview. Yeah, that one.
Oh,
So
that
maybe if you
one.
click, yeah.
Maybe. Now, hopefully it's okay now.
Uh, that box is still there. Right? We can't see it moving still.
Now,
Yeah, if you can click that and see.
right, I click it. Is it moving now?
No, it's not moving for us. Maybe if you close down the PowerPoint and restart sometimes.
Yes. Sorry for the
That's
disturbance. I will close down it again and start it. Is it moving now?
no, we can't see any movement. Is it moving on your
Yes, it's moving on my screen actually.
uh,
Now,
no, still can't see any movement. If you make it full screen, will it work? It was moving before when we tried for the
yes.
start. Yeah,
Is it now moving?
yeah, we are on the overview side now.
Yeah, now
Yeah, it's moving now.
I think it's when you put it into the slideshow,
Yeah,
it's not moving.
all right. Maybe we can proceed like this. We can see the sides.
Yes, I think
Yeah,
that will be. Sorry
yeah,
about the interruption. I think time to time, this kind of problems are coming up.
yeah. That's right.
Right. So I have discussed already the epidemiology. So considering the burden of the disease, this is a major public health problem. As a Sri Lankans, we are not seeing this thing, but considering other part of the world, especially in African region and the Southeast Asia, this is a major problem. You are nearly 820,000 people died every year, especially in 2019, due to hepatitis B virus infection and its complications. So moving into global epidemiology, the epidemiology mainly characterized by the prevalence of the hepatitis B surface antigen in any community. So the main prevalence, they have into three divisions. That high prevalence, they considered more than 8% of the hepatitis B surface antigen prevalence in the population. Then the intermediate is 2 to 7% and low prevalence is less than 2%. According to WHO, the African region and the Wipro region, the Western Pacific region, has the highest prevalence of hepatitis B viral infection in the world. Moving into Sri Lankan epidemiology, Sri Lanka is considered as a low seroprevalence country with estimated seroprevalence is around 1.9%. Mind you, this is estimated seroprevalence. There's no island-wide epidemiological data. So we don't know now this 1.9 is a correct one or not actually. This low prevalence might be due to the socio-economic and cultural factors in Sri Lanka, but the other factors like hepatitis B immunization campaign, then the safe sex practices, then less IV drug abusers and they improve their practices, then the infection control methods, then the transfusion screening methods, these everything has contributed to low prevalence in our country. However, the other hand, the countries near Sri Lanka with frequent movements like India, China, Pakistan, we has a high seroprevalence for hepatitis B surface antigen. So we are at anyway in a risk. In Sri Lanka, time to time, we have seen hepatitis B clusters from cancer units, mental health care units, and prisons. And most of the other time, we have found that many family clusters. One family member is infected. When we try to screen the other people, often we notice that maybe 4 to 5 other family members already infected with hepatitis B viral infection. So in Sri Lanka also, although the prevalence is less, this has some public health important as well. So moving into a little bit of a virology, hepatitis B virus is a hepatovirus. It's a small envelope virus, but one important thing in clinical practice is that this is very hardy virus, very resistant to physical and chemical damage. Once if this virus can even survive more than 7 days in surfaces. If you're considering a small blood spill, maybe the spillage surface, this virus lasts for more than 7 to 8 days. So there's a high chance of getting infection to another person. At the same time, this virus has three different characteristic features. While its multiplication, it will produce like non-infectious particles during its multiplication, large quantities, which come back with our immune system. So our immune system attacks these non-viral particles, non-infectious particles as well. So indirectly, the live virus, the infectious virus also will survive because of the competition. Same thing, the hepatitis B the genome and everything. I don't go in much detail into this one. The important thing is once hepatitis B virus is infected a person, this hepatitis B virus genome is integrated into our host genome. So it cannot be eradicated from our host cells. Although maybe you can remove the infectious virus, but viral genomic particles remain in our hepatocytes. So once patient become immunocompromised, this virus can be reactivated and can produce multiple virions and produce disease and progression into the liver disease again. According to the genetic structure, hepatitis B virus has several genotypes, A to G, and their distribution is different from different parts of the world. Sometimes these genotypes may contribute to the disease pathogenesis, that our clinical outcome, and also may be responsible for the treatment response as well. But at the moment, the hepatitis B genotyping is not recommended for before starting treatment as compared to hepatitis C viral infection. There are many transmission modes, mainly transmitted by parental route. The mucous membranes exposure or percutaneous contacts through infectious body fluids. This can be transmitted to the other person, and also transfusion of blood and blood products, maybe using injectable drugs or sharing needles, hemodialysis. Then the accident needle prick injuries can cause the transmission to a non-infected person. Then it can be transmitted sexually, and it can be transmitted through perinatal route as well. The other important route of transmission, we don't know at the moment what is the exact route, but there are considerable horizontal transmission occurs during close contacts and the close family members. This is very important when we are managing patient in the clinical setup. We have to prevent the transmission to the other persons as well. Moving on to pathogenesis, hepatitis B is not a cytopathic virus. So virus itself do not destroy the hepatocytes. The hepatocyte destruction is due to our immune response, the host immune response. And the outcome is very complex. It's determined by the host factors as well as the viral factors as well. The patient's age, patient gender, immune status are very important for the patient's outcome. And some may go into chronic infection, some may settle in the acute infection. So if you acquire this disease in perinatal period, almost 90 to 95% will go into the chronicity. Around childhood, around 40 to 50% will go into chronicity. But however, if adults adult immunocompetent patients develop hepatitis B viral infections, almost 5 to 10% will go into chronicity. Almost 90 to 95% will recover from the acute infection spontaneously. So in this case, this is very important in our setups as well. We have to prevent transmission, especially from mother to child transmission at perinatal level and the childhood, because there will be more chance of getting chronicity and more chance of getting chronic infection, asymptomatic infection into the community, which can act as a reservoir for the infection. Clinical phases, there's two main consequences. One, it may be acute infection, maybe chronic infection. In acute infection, it's a very short duration, less than 6 months. Acute infection can be asymptomatic, may present as acute viral hepatitis, or may present as a fulminant hepatitis as well. But the period of viral multiplication and the presence of hepatitis B surface antigen is less than 6 months. The chronic infection, where we considered as a duration is more than 6 months, then can go into chronic hepatitis B viral infection, can go into cirrhosis, then may be compensated or decompensated and go into the hepatocellular carcinoma as well. Moving on to acute hepatitis B infection. Usually the hepatitis B incubation period is 6 to 9 days, but it can be varied up to 40 to 180 days. So incubation period is more longer than compared to hepatitis A or hepatitis C viral infection. Acute infection may be asymptomatic in majority of the population, especially in young age groups. Usually symptoms, it's very similar to hepatitis A viral infection and present as a prodromal, like malaise, anorexia, weakness, myalgia, then nausea, vomiting. Then it's go into jaundice phase, upper right abdominal pain, and then dark color urine and pale stools like typical viral hepatitis. And it goes gradually and get recovered. But in this case, some may go into fulminant hepatitis, may require intensive care admission and treatment as well. Moving on to chronic hepatitis B infection, that we consider chronic hepatitis B, where the hepatitis B surface antigen or DNA is detectable in blood more than 6 months in a patient. It occurs mainly in young patients when they acquired in young age group. Neonates may go up to 90% of them go up to chronicity. Maybe children less than 6 years, maybe 20 to 50% will go up to chronicity. If the adult, if they develop, they go on to 5 to 10% into the chronicity as well. In chronic infections divided into 5 stages. We called it high replicative phase, this early phase, then immunoclearance phase, then low non-replicative phase, then surface antigen negative, then surface E antigen negative phase and E antigen antibody development phase, then surface antigen loss phase as well. So chronic hepatitis B has some different phases. Maybe these are overlapping. Sometimes these typical infection may not be present in all the cases. So moving on to laboratory diagnosis, I think this is the part of our field. I will discuss on this one more. Laboratory diagnosis in hepatitis B, there are two different ones. Ones are serological markers, Others are molecular markers. The serological markers are the hepatitis B surface antigen, anti-hepatitis B co-total antibody, then the hepatitis B co-IgM antibodies, hepatitis E antigen, anti-hepatitis B E antibodies, then anti-hepatitis B surface antibodies, and there's a new test that sometimes if doubtful results comes, hepatitis B confirmation, surface antigen confirmation assay by using utilization assays. Then there are molecular markers that we are testing hepatitis B viral DNA. Some tests are qualitative, just detect only the DNA. That's to confirm the infection, but as a assessment of the patient as well as the assessment of the treatment response, we can check for the hepatitis B DNA levels. That is quantitative test. We call it hepatitis B DNA level or hepatitis B viral load. So any markers, they have any importance. Hepatitis B surface antigen appears early in the infection as well, which indicate the patient is having hepatitis B viral infection. And anti-hepatitis B co-IgM, which is the antibody appears in the early phase of the illness. It's an indicator of an acute infection. Usually, this co-IgM will last 3 to 4 months following infection. So if it is an acute infection, this antibody is present. It indicates this infection is very recently acquired one. Then another marker is anti-HBC co-total antibody, which indicate the exposure to the infection. So once this co-total antibody develops in the person, it will last for a lifelong. So it will gives the indication that there is a past exposure as well. Hepatitis B E antigen is a marker where it indicates a high infectivity, because this E antigen occurs when the viral is multiplication, and when its multiplication is very high, large amount of hepatitis E antigen is secreted into the blood. So hepatitis E antigen positivity means the patient is high, has a high infectivity, and it's ongoing active multiplication of virus is going on, as well as acute hepatitis is going on. So anti-hepatitis B E antibody is a marker of actually our treatment goal. Is when hepatitis B E antigen has disappeared from the blood, hepatitis B E antibody will appear and it acts as a marker for our treatment response. The same thing, the marker and our interpretation. If it is hepatitis B co-total antibody positive, it gives an indicator there is an exposure to hepatitis B viral infection. So if it is hepatitis B co-IgM is positive, it indicates it's acute infection. The exposure is not beyond 3 to 4 months. So you can differentiate with using hepatitis B co-IgM whether this is acute hepatitis or chronic hepatitis. If hepatitis B surface antigen is a marker of hepatitis B infection, so it is present in the acute, chronic, inactive carriers as well. Hepatitis E antigen is a marker with the acute active viral multiplication, so it's present in the acute infection as well as the chronic infection as well. Hepatitis E antibody occurs especially in inactive carriers as well as sometimes in the chronic hepatitis B carriers as well. The surface antibody occurs after disappearance of the surface antigen. So it is an indicator of immunity following infection, or sometimes the immunity following vaccination if the patient is vaccinated. So, but if you can differentiate this one, immunity following infection with immunity following vaccination, unless patient is not sure, we can go for a co-total antibody. In a co-total antibody, it should be positive in immunity following infection, but co-total is negative in the immunity following vaccination. This is actually a basic overview of interpretation of our serology results. So when you go to diagnosis of acute infection, for acute infection, usually we diagnose by the doing hepatitis B surface antigen, followed by hepatitis B DNA and IgM antibodies for core antigen. In diagnosis of acute infection, E antigen always positive, and this infection will clear after appearing of anti-HBs antigen. This is how the viral kinetics of acute hepatitis B infection. Once the hepatitis B surface antigen is cleared, the hepatitis B antibody will appear. So diagnosis of chronic infection, little bit of complicated. Always hepatitis B surface antigen will be there. Then hepatitis B co-total antibody will be also positive. And then we have to check for a hepatitis E antigen and E antibody, whether this is a active hepatitis is going on already or it is going into inactive phase. In our local laboratory setting, what we do is when we receive a sample from a patient, there's a suspected patient, it can be a screening patient or can be even referred from a blood bank. We usually start to doing hepatitis B surface antigen in the initial sample. If this hepatitis B surface antigen is detected in this sample, we say it's reactive because we never confirm with the one. We repeat it with a different method or a different marker, and we confirm it. This sample is positive for hepatitis B surface antigen. Because this disease has carried some stigma and there may be problems with the sample handling or maybe labeling or anything. So what we do is before confirmation, we get down a second sample from the same patient and we test it again for the surface antigen. And if it is positive, we confirm that patient has hepatitis B infected patient. We always do confirm the sample, repeat in the same sample, and we get down another new sample from the same patient and we do it, repeat it again. And if it is positive, we confirm this patient as hepatitis B infected and we will inform to the clinicians. At the same time, we will do the serology profile and the DNA levels and send it to the relevant clinicians. With the patients who already confirm with hepatitis B surface antigen positive and also follow up in the gastroenterology units, we do the serology profile and DNA levels time to time according to the guidelines. If the patients need some assessment of immunity following vaccination, the healthcare workers or the close contacts, we do the anti-HBs antibody levels. Usually we recommended 4 to 6 weeks after the last dose of vaccination. And another group need a hepatitis B serology profiles who are awaiting immunosuppression. As this virus is integrated into our host genome, sometimes these can be reactivated following immunosuppression. So therefore, all people who are awaiting immunosuppression, especially biologics, maybe undergoing transplantation, have to do hepatitis B surface antigen as well as co-total antibody as well. Because hepatitis B surface antigen will exclude the hepatitis B viral infection. The co-total antibody will be with you if they are in past exposure. So that is very important. Especially patients who are waiting immunosuppression, please request hepatitis B co-total antibody as well. Especially in your sector, the patients who are waiting liver transplant as well. So a little bit of about how to do this diagnosis. This is very important with the sample collection and transport for hepatitis B surface antigen and the serology profile. Please instruct your junior colleagues regarding this one. We request 3 to 5 ml of venous blood, usually collected into a sterile, dry screw cap or tube with or without anticoagulant. Usually we ask to put it into a plain tube, label and ask keep it room temperature for 30 minutes and transport in room temperature. If any delays, you can keep it in +4 for 24 to 48 hours. And if it's delays, sometimes these samples has to be sent into a other laboratories, sometimes away from the province, away from the district. So ask your microbiology or the just pathology laboratory to separate the serum and only send the serum part to the reference laboratory. And contaminated or hemolyzed samples are not recommended for hepatitis B surface antigen testing or serology profile. Moving on to how to collect the sample and transport for the blood for hepatitis B DNA detection or viral detection. We asked to collect 3 to 5 ml of venous blood into sterile dry screw cap bottle, usually EDTA tube. We prefer EDTA sample for the molecular testing, and it should be transported soon as possible with ice to the laboratory. If delay, you can keep it in +4 up to 48 hours in a refrigerator, but do not freeze it. Because this is very important, because your treatment plan, maybe your treatment response is detection is depending on the viral load. So the quality of sample is very important. Otherwise, it will give the false negative results. So there may be the viral load may be changed. There's an alteration of the detection. So for this one, hemolyzed and contaminated samples are also not suitable. If you're thinking of any delays to sending into the reference lab, ask your microbiology or pathology laboratory to separate the plasma and send the plasma component. And usually for follow-up patients, because you need to check your virological response after treatment, sometimes it's very important. So it's better to send to the same laboratory, because the uniformity will be there, because subtle change of the method or testing method, testing kit, even these laboratories use external QCs, the subtle change of the method or kit maybe affect the viral load. So it gives some negative impact into your management, because once one viral load, if you after starting the treatment, viral load is high, whether these problems might occur and it's a true increase, or whether it's due to some problem in the initial sample, we have to think about it, because otherwise we have to think about the viral resistance as well. So that's what I think often I recommend, that if you can send a sample, especially the follow-up samples during the treatment, to the same laboratory, it will be helpful for you all. So I will talk about a little bit of availability of laboratory tests in Sri Lanka. The hepatitis B surface antigen is available in Medical Research Institute, then all 3 regional virology laboratories, and Apeksha Hospital, Maharagama as well. Then some teaching hospitals and some provincial general hospitals also doing small scale hepatitis B surface antigen as a screening test, and also available in the private labs as well. So serology profile is currently available in Medical Research Institute, as well as 3 virology laboratories in the country, and also in the Apeksha Hospital, and also in the private labs as well. Then the hepatitis B DNA is available in private labs and university labs. That is not the viral load, just a qualitative test. And hepatitis B DNA level of viral load is also available in MRI and all 3 virology labs, and some private labs and the university labs as well. So please direct into your closest virology laboratory to get the results as soon as possible. Usually we do these tests maybe once in every 2 weeks, right? Usually the reagents are available. Because of this current economic crisis, maybe some laboratories has some drawbacks, but usually we do, like, it is a batch test, the viral load. So we usually collect the samples and do it every other week, like. But if you need to do it in urgently, please contact your sending laboratory, then they will arrange it as early as possible. So when coming into diagnosis, there are some bit of a diagnostic dilemmas as well, some problematic sometimes, especially if the screening test is reactive, because sometimes some private laboratories and the small scale laboratories, they do this rapid testing for hepatitis B surface antigen, and sometimes it can give false positive results. So always these rapid test results should be referred to a virology lab for confirmation before informing into the patient and the relatives as well, because otherwise it will cause another set of a problem. And sometimes there may be unusual situations. Sometimes both hepatitis B, E antigen and antibody might be detected in some cases. This is a transitional period of hepatitis B, E antibody seroconversion period. Sometimes hepatitis B surface antigen and antibody both can be present. This is also maybe transitional period, and sometimes even maybe reactivation, because these days some assays are very sensitive. So even a minute amount of antigen antibody, they can detect it. And in some patients, there are repeatedly hepatitis B surface antigen is reactive, that means detected, but other serological markers and DNAs are negative. Maybe these are due to biological false positives. So in these cases, we have to go for the hepatitis B surface antigen confirmatory assay. That's a neutralization assay. And please remember some areas, especially in Mediterranean, there's hepatitis B surface antigen mutants are there. If your suspecting patient is having viral hepatitis, then surface antigen is negative with the travel history, please consider these cases as well. And sometimes there may be isolated co-total antibody positivity, so we have to investigate these by case basis. So moving on to clinical management, I think these are very familiar for your section, so I don't go into much details on these ones. More than 90% of the immunocompetent adults with acute hepatitis B infection is usually resolving spontaneously. Only supportive therapy is required. But sometimes it can go into a severe acute disease or severe acute pulmonary hepatitis. So then the antiviral treatment is recommended. The antiviral drug of choice is entecavir, then tenofovir you can use, but peg interferon is not recommended in acute infection. So this is where that co-IgM is come into play. So you can get the support from the laboratory at this stage. But sometimes the fulminant liver failure may need liver transplantation as well. Moving on to chronic hepatitis B management, our treatment goal is to inhibit hepatitis B viral replication and prevent the progression of the liver disease into cirrhosis, liver failure, and hepatocellular carcinoma. So our treatment goal is the achievement is for our hepatitis B E antibody seroconversion. So patients need therapy. You can give interferon or long-term plus suppressive therapy with nucleoside or nucleotide analog drugs given. PEG interferon approach is induced to long-term immunological control. And people who are not responding to PEG interferon or has a contraindication, you can go for a nucleoside analogs only. So there are many nucleoside analogs approved for hepatitis B viral infection management. I think you are very familiar on these things. Like lamivudine now due to resistance is not in very use. Then lifovir, then entecavir, terfovir, tenofovir, you can use for this one. And some these drugs has low resistance barriers, some has high resistance barriers. So depending on this one, you have to treat the selection. And make sure when you are managing hepatitis B to exclude hepatitis C and HIV viral infections as well. I think that should come into the diagnosis part as well. Then these patients should be followed up with the virological response, then serological response, biological and histological response. So time to time, you have to do the serological markers as well as hepatitis B viral DNA levels according to your own protocol you are following up. So nucleoside analogs, so tide analogs should be discontinued after confirming the hepatitis B surface antigen loss with or without HBs seroconversion. Usually surface antibody seroconversion occurs only 10 to 15% per annually. Anyway, patients who are under effective long-term antiviral drug therapy should remain under surveillance for hepatocellular carcinoma, and all patients should be cirrhosis as well as other high-risk cases should be put into the nucleoside analog therapy. Then there are special groups with hepatitis B viral infections you have to be attended on. One is HIV co-infected patients. So all HIV positive patients with B co-infection should be started antiretroviral therapy, irrespective of the CD4 cell count. So they should be treated with tenofovir-based ART regime, because some drugs they used in the HIV also used in the hepatitis B management as well. Then another infection, because of mode of transmission is very similar, that hepatitis C viral infection also can be present with the hepatitis B viral infections. So the treatment of HCV can be considered by the directly acting antiviral drugs at the same time, and they should manage according to their protocol. In children, it's very important to prevent the progression of the disease. Treatment criteria, they should be treated with nucleoside analogs or nucleotide analogs and regulated interferon within this population. Then healthcare workers also need to be treated because they can be a source for the other community as well. Then we have to put special emphasis on the pregnancy, because the perinatal transmission can lead into chronicity, especially in children. So hepatitis B surface antigen should be done in the first trimester as a screening test for the pregnancy. If a woman with a childbearing age without advanced fibrosis who plans pregnancy in the near future, they delay the therapy until the child is born. You can delay it. When the pregnant woman has advanced fibrosis, therapy of tenofovir is recommended. And the pregnancy is already on, you can consider about the suppressive therapy depending on the viral load. The thing is, remember is that if we have to prevent the mother-to-child transmission or perinatal transmission, so we have to be ready with the prophylaxis to the baby. So for prophylaxis is depending on the viral load and the E antibody status. If the patient is having hepatitis B E antibody, the baby only requires the vaccination. But if there's no evidence of hepatitis B E antibody in the patient and the viral load is less than more than 10 to the power 6, then you have to give for the immunoglobulin to the baby within 12 hours of birth. So after birth, breastfeeding, this is another big query everybody is asking. Breastfeeding is not contraindicated for hepatitis B positive mothers unless there's a prophylaxis is not given in timely manner. If the prophylaxis is ready, you can give within 12 hours. So you can ask them to breastfeed at the time of birth. Then patients who are undergoing immunosuppressed therapy or chemotherapy should tested for hepatitis B markers prior to immunosuppression, if surface antigen and the total antibody. If all hepatitis B surface antigen positive patients should receive antiviral treatment or prophylaxis at the time of immunosuppression. And another group is very important is dialysis and renal transplant patients. All dialysis and renal transplant should receive for screening for markers, and we recommended them to vaccinate. And surface antigen positive dialysis patient who requires treatment should receive antiviral treatment, and dedicated dialysis machine should be allocated for these patients as well. So there are prevention, actually prevention mainly two times. The one is by immunization as well as the behavioral modification. The active immunization is given by the vaccination. The passive immunization by the giving hepatitis B specific immunoglobulins. So there are groups you need hepatitis B vaccination, especially high risk groups. Like healthcare workers, then the injectable drug users, like that, these groups. I think I don't go into that details on this. And the passive immunization, we can give it as a prophylaxis method. This is depending on the clinical situation. Especially we use this one for accidental exposure to the healthcare workers who has no evidence for immunity against hepatitis B viral infection, as well as newborns born into hepatitis B positive mothers with no evidence of hepatitis B E antibody seroconversion. Then we have to do some modification of risk behaviors and everything, the blood transfusion safety, the health education, as well as infection control measures to prevent this infection in the community and the hospital setting. And also very important thing, once you get the hepatitis B positive patient, it's very important to prevent transmission among the society and among family members and the close contacts. Because this is a very hardy virus, can be survive in the surfaces for a long time, and it's secreted in a many secretions. So their close contacts can get infection very rapidly, as well as they are in risk. So high risk for these infections are spouse, definitely through the sexual route as a and horizontal route. Then other close contacts, especially close family members, and if their patient is staying in a like long-term care facility, the other members as well. So it's better if you can refer the close contacts or ask the patient to send the contacts to your closest virology or microbiology unit. So we will do this contact screening for all contacts by doing hepatitis B surface antigen and or total antibody. And we do the counseling and enforce preventive measures till the reports available, as well as their immune status is get on. We offer the vaccination for immune or non-infected individuals, and we ask them to follow up screening for immunity as well. So this is very important to break through the transmission cycle as well, because we have come across that one patient is positive, maybe few families, even in Kandy, maybe 5 or 6 family members already infected at that time. And in future management, in future, there are some new biomarkers coming up. This is DNA, then hepatitis B antigen, HBV RNA, and there are many future options in the future management as well. Some immunomodulators, immunotherapeutic agents, new antiviral drugs are on pipeline. So this will be available in near future. Coming into problems in our local setting, is a one major obstacle is limited availability of laboratory diagnosis. As you know, I think only few laboratories are doing hepatitis B surface antigen, then the viral load and the serology profile as well. So serology profile and the viral load is very expensive. Sometimes this viral load will cost 10,000 to 12,000 rupees. Even full serology profile will cost nearly 10,000 rupees. So most patients can't afford these things. And also the antiviral drugs availability is very limited. Only few drugs are registered, some are not registered in the country, and time to time there are many shortages as well. And we don't know about the local antiviral resistant patterns as well. So that is a one problem. We have to go blindly with the virologic response and everything. We don't have data on this one. And situation of hepatitis D viral infection in Sri Lanka, we never know. We have to do some research on this one as well. The other major problem is unavailability of hepatitis B specific immunoglobulin most of the time. This is not a registered product. So sometimes managing of a pregnant uh, one with the prevention to child or after needle sticks exposure, this is a very problematic one. That's why we always recommended to healthcare workers to get the fully vaccinated, and immunostatus should be checked before they starting their routine work. Another thing is how we utilize our available laboratory diagnostic facilities in optimal manner. So we have to advise how to get the proper collection and transport of this specimen, because these tests are very costly. So you can get the correct results. The other thing is request forms. We have to add some proper clinical history. What test the clinician should require, because if they already we know the diagnosed patient with total is positive, E antigen positive. If you want to check only the E antibody, just ask what is the test, because then we can omit other tests. Otherwise, laboratory people put whole serology profile on each and every person. So we have to use it in a rational manner. And if you can put the previous laboratory results, especially serology profile and the viral load in a request form for patients who are following up, then we can go through and select the test, appropriate test, and give the good results to the clinician. And also we have to do something on proper method of disseminating the laboratory results. Because once you do the laboratory testing, the results should go into the relevant clinicians, but come across these reports are stagnated in the laboratory as well as the intermediate centers as well. So this is we have to think about how to improve and how to use available limited laboratory resources as well. So thank you very much. Do you have any questions regarding the laboratory testing? Hello, can you hear me? Any questions? There's one question is asking, what do you think about double dose of hepatitis B vaccination? So double dose of hepatitis B vaccination is recommended in immunocompromised patients, as well as maybe patients who are in chronic renal failure. You can give double dose of hepatitis B vaccination. And also sometimes you can use accelerated schedule if you need immunity quickly, if you want to go travel, or if you are waiting in employment or accidental exposures, but immunoglobulin is not available, you can go for an accelerated schedule. That's 0, 2 weeks, one month, then the booster dose in 1 year. Is there any questions? Or I think there are no other questions. So thank you very much for inviting me to present this presentation. So I was trying to do mainly the how to utilize our available laboratory facilities in efficient manner. I think then we can give some help for you all as a gastroenterologist to manage the patient. So we will continue our support and we will have a good dialogue between us. And what you want, please let us know. Then we will arrange those things as well. Thank you very much.